People will start coming in now because it's 11:59. Once everyone's in the room and the attendance balances out, I'll get the signal to Ms. Elgin to begin.
My name is how I do that here. I don't.
Ms. Elgin, you can begin when you'd like.
Good morning or afternoon, depending on where you are joining us from. I am Lisa Elgin, Chairwoman of the California Rural Indian Health Board and Secretary of the National Indian Health Board. It is my pleasure to welcome you to the Centers for Disease Control and Prevention listening session of the 2022 National Tribal Public Health Summit. And before we begin, please note that this session is being recorded. If you do not consent to be recorded, you are asked to drop off the session at this time. Thank you. As is customary, we will start this meeting in a good way with an opening prayer. Now I'm gonna do that real quick. Oya Kapade, Creator, we come today to you with so many things, so many blessings. We're blessed for a new day, blessed to get up today. And we know you're gonna walk this way with all of us today. Give us good thoughts, give us good intentions, and let us just get through today and the next couple days in a good way. We know you are with us. We ask that you be with everyone around the country and everyone joining us virtually. We have hard times, but together we get through it. And we ask that you just continue to show us guidance, show us strength, and then get us through what we need to do. With that, I say, yeah, we thank you. Oh. To help lead today's session, I will be joined by NIHB Portland Area Representative and CDC Tribal Advisory Committee Delegate, Nate Tyler. Nate.
You're muted, Councilman.
Sorry about that. Appreciate that, Chairwoman Elgin. Today, we're lucky enough to be joined by the Director of the Center of Disease Control and Prevention and the Administrator for the Agency for Toxic Substances and Disease Registry, Dr. Rochelle Walensky. Due to a scheduling conflict, Dr. Walensky will only be able to join us for the first 20 minutes of today's session. Since our time is short, I will now turn it over to Dr. Walensky for remarks and questions. Appreciate it.
Thank you so very much. I'm honored to open today's listening session and to reaffirm our government-to-government relationship on behalf of CDC and ATSDR. At CDC, we strongly support and respect tribal sovereignty and self-determination for tribal governments in the United States, and we appreciate our ongoing collaboration to protect and improve public health. I'd like to acknowledge the Muskogee and Cherokee Nations whose indigenous lands we are on at CDC's Atlanta campus. Accompanying me today are Dr. Jose Montero, Director of CDC's Center for State, Tribal, Local, and Territorial Support, or CSTLS, Ms. Georgia Moore, CSTL's Acting Director of the Office of Tribal Affairs and Strategic Alliances, and Dr. Juliana Reese, Director of Healthy Tribes for the National Center for Chronic Disease Prevention and Health Promotion, Division of Population Health. Unfortunately, because of competing commitments, I will have to leave earlier than I would like. When I leave, Dr. Montero, Ms. Moore, and Dr. Reese will remain to receive your input, your recommendations, and will share those with me. Again, I'm honored to join all of you today. This afternoon, I will provide a few updates on CDC's engagement with tribes, funding, training, and the COVID-19 response. And then I look forward to hearing from you before I must leave. In January, in partnership with NIHB, we held a listening session on the Hear Her campaign to support healthy American Indian and Alaska Native pregnancies and promote postpartum health. The listening section focused on important health topics, such as health disparities, trust building, and culturally appropriate messaging. And with support from CDC funding, NIHB hosted 3 listening sessions on the 2019 Public Health in Indian Country Capacity scan to discuss tribal public health workforce, data, authority, governance, and exercising sovereignty. We will use the feedback from these listening sessions and the NIHB strategic plan consultation held February 3rd to better tailor our programs to serve tribal communities. I extend my personal gratitude for all the tribal partners for all of your help in advancing this critically important work. We also held a listening session with tribal leaders and tribal programs for our diabetes prevention or Prevent T2 curriculum to make sure this program reflects cultural values, social and environmental relationships, and intervening forces. This effort has included focus groups, talking circles, message testing, and feedback from a panel of seasoned coaches. And we're working to recruit and train more Indigenous public health leaders through the new Indigenous Public Health Leadership Program, developed in partnership with the National Network of Public Health Institutes, 7 Directions Indigenous Public Health Institute, and the American Indian Public Health Resource Center. This program is training emerging tribal public health leaders in core public health competencies with a key focus on issues impacting tribal communities. And the first cohort began training, I'm happy to say, on March 16th. We know that access to tribal public health data continues to be an important issue. The tribal epidemiology centers have access to COVID-19 data from the Vaccine Adverse Event Reporting System, or VAERS, through HHS Protects. In November 2021, the Northwest Portland Area Indian Health Board announced the launch of a free online resource supported by CDC that offers practical guidance for federally recognized tribes and tribal serving organizations on obtaining and sharing health data. This free, innovative platform supports data and sharing in ways that honor tribal sovereignty, data sovereignty, and public health authority to advance the health and healthcare of Native communities. A real concern that we're missing is that we're missing data on race and ethnicity in many areas. This fiscal year, the National Center for Health Statistics, or NCHS, is working to improve the data collection of American Indian and Alaska Native mortality statistics by conducting targeted outreach and training for funeral directors, including training to reinforce existing guidance that funeral directors consult with the decedent's family or close friends when determining race and ethnicity. CSTLS has awarded funds from the Tribal Public Health Capacity Building and Quality Improvement Umbrella Cooperative Agreement to all 25 American Indian and Alaska Native tribal nations and regional American Indian and Alaska Native tribal designated organizations. This cooperative agreement will provide approximately $1.6 million for an environmental scan of data capacity within tribal organizations. This effort feeds into CDC's data modernization initiative, an initiative that is improving automation of race, ethnicity, and other demographic data in collection and bringing data closer to the point of care to get information faster and more accurately. Under this same cooperative agreement, CDC is providing a $7.5 million supplemental funding opportunity. And in addition to the $15 million in continuation funding, for a total of $21.5 million in fiscal year 2022 funds for the grantees. Recipients have the opportunity to work on a variety of tribal public health infrastructure strengthening projects, including establishing a peer network for National Diabetes Prevention Program lifestyle coaches and coordinators in tribal organizations, expanding wastewater surveillance for COVID-19 in tribal communities, strengthening COVID-19 vaccine confidence and demand through communication, education, and outreach, supporting tribal epidemiology-centered drug and overdose opioid overdose capacity, reviewing tribal maternal mortality data, and supporting tribal public health data modernization. Applications are due Friday, June 10th at 11:59 p.m. Eastern Time, and I encourage you to take advantage of this funding. Let me close, please, with a brief update on the state of the COVID-19 pandemic and on our commitment to working with tribal nations to respond. We know that vaccination is critical for protection against COVID. It was the efforts of those in 356 tribal facilities enrolled through Indian Health Service and 227 facilities enrolled through their respective states, that helped over 60% of American, Indian, and Alaska Native individuals receive their primary vaccine series, as compared to 49% of white individuals. Soon we will reach the grim milestone of 1 million reported deaths from COVID-19 in the United States. This is a heartbreaking reminder that COVID-19 is still with us. CDC remains concerned about the effects that COVID-19 has on the American Indian and Alaska Native populations. American Indian and Alaska Native individuals show rates for infections to be 1.6 times higher, hospitalizations to be 3.1 times higher, and deaths to be 2.1 times higher than those of white non-Hispanic people. Persistent racial inequity and historical trauma have contributed to these disparities. In 2020, CDC provided hands-on and remote assistance to requesting tribal nations on risk mitigation and prevention strategies, covering topics like shared transportation, access to running water in homes, and multi-generational housing, to just name a few. Vaccines have been the best tool to limit the impact of COVID-19. Since their release, much of CDC's response has been focused on assisting national partners and requesting tribal nations to build vaccine confidence. In particular, CDC's Tribal Support Section Vaccination Unit has been adapting vaccine confidence resources to address barriers and increase vaccine confidence, specifically in American Indian and Alaska Native communities, and is available to provide virtual training with tips and best practices for building vaccine confidence. CDC's deployment teams continue to provide hands-on assistance to requesting tribal nations on a variety of COVID-19 prevention strategies, including the most recent deployment of a tribal rapid assessment team to assist with case investigation, contact tracing, community mitigation, epidemiology, surveillance, health and risk communications, and response management, assisting a tribe with preparation for town hall meetings to address vaccine misinformation, and responding to questions about the vaccine, breakthrough infections, COVID testing, and measures to reduce the risk of the spread of COVID in schools. I'd like to close my formal remarks by restating how important the government-to-government relationship with tribal nations is to me and CDC ATSDR. Thank you again for the opportunity to join you all today. I will turn the podium back over to our moderators, Ms. Elgin and Mr. Tyler, for your questions in the remaining time that we have together. Thank you so much.
Thank you for those comments, Dr. Walensky. I would like to kick us off with a question regarding tribal public health infrastructure. 2019 Public Health in Indian Country Capacity Scan, FIX, reported that tribes are the primary provider of public health activities in Indian Country across all public health activity and service categories. Tribal public health systems are highly variable and often complex. A variety of tribal agencies deliver public health services in addition to numerous tribal and non-tribal external entities, including federal agencies, state and local health departments. The 2019 FIX report also highlighted gaps in public health planning, assessment, quality improvement activities, accreditation, and tribal law as a public health tool. Future efforts in public health infrastructure should focus on building capacity at a local level. With sufficient investment and complete tribal control, tribes can adapt their public health infrastructure to meet the unique needs of their people and circumstances. This will lead to innovation and advances that will protect public health for American Indian and Alaska Native peoples for decades to come. So my question is, how does the CDC plan to support tribes through the funding and other resources, including but not limited to NIHB's Public Health in Indian Country Capacity Scan, to develop public health infrastructure priorities as identified by elected tribal leaders, and build programs to address those priorities? What actions will CDC take to recognize and support tribal public health authority?
Thank you so much for that question, Ms. Elgin. Maybe what I'll do is start and then pass it over to Georgia to sort of give you more details, except to say that one of the things I think that's critically important, as we've seen in this pandemic, in addition to the pandemic, is how the foundation of public health across the country, exactly as you describe in tribal nation as well, has been too frail to handle the pandemic itself. And that what we really need is a workforce that is skilled up and is as diverse as the communities that we serve. And so one of my big goals in creating this public health infrastructure, exactly as you described, is to work towards making sure that our data systems and our workforce systems create an infrastructure that is as diverse as the communities that they serve, exactly as you know. So maybe I'll pass to Ms. Moore to speak further on the specifics that we're doing with tribal nations in order to lead to that end goal.
Sure. Thank you, Dr. Walensky. We will definitely continue our commitment to the tribal public health infrastructure building programs that we do currently have. Dr. Walensky referred to the money that we were putting out through that cooperative agreement. We hope to build that to fund more tribal recipients. We will continue with our Healthy Tribes programs in Juliana Reese's Center. We're going to continue to look at the data issues across CDC, working with those systems to build that part of the tribal public health system and just continue those commitments. And we're also, from the tribal COVID grant and those other cooperative agreements, we are looking at and measuring what the tribal recipients decided to spend funding on, which shows where the needs lie. And then also going to look at lessons learned from that grant and share those lessons learned so they can be applied across Indian Country. And it will also inform our future funding opportunities to support you. And I'll see if Dr. Montero would like to add any information to that.
Thank you, Georgia. The only thing that I would add is that certainly we have really important partners in the tribal community. We have several different funding vehicles where we support the National Indian Health Board and we support NIHB, the Urban Indian Group. So we try to have a quite comprehensive approach that allows us to go and identify what is needed in Indian Country, and then other vehicles that allows us to finance part of that. As we have said before, CDC is not alone on this space. A lot of the coordination with Indian Health Services needs to continue because they are a key funding partner in many of these areas as well. The scan of the needs in public health was funded by CDC, performed through our partnership with the National Indian Health Board, and we will continue to work on those areas. Thank you.
Thank you all for your responses. We know that you do have to depart, Dr. Walensky, so I appreciate all the comments and feedback from all of you. So thank you so much for joining us today. And if you don't have any closing comments, we wish you well on your way and appreciate the time.
Thank you so much, Ms. Elgin and Mr. Tyler. I really appreciate the opportunity to join you today. I will delegate my chair to Dr. Montero, Ms. Moore, and Dr. Reese for the duration of the meeting and just extend my gratitude and collaboration. Thank you.
Thank you. So thank you so much for joining us. We will now be joined by Dr. Jose Montero, Director of the Center for State, Tribal, Local, Territorial Support, Dr. Juliana Reese, Director of the Healthy Tribes Program, and other key CDC leadership, and Georgia Moore, Acting Director of the Office of Tribal Affairs and Strategic Alliances. We appreciate the engagement with Dr. Montero and other CDC leadership, and we look forward to discussing a host of issues that are important to our tribal nations. Nate?
Thank you, Chairwoman. As we have already seen, we have many important topics of discussion today on current and ongoing public health challenges affecting tribal nations, emergency preparedness, and concerns around the ongoing COVID-19 public health emergency are, of course, at the front of everyone's mind. However, other public health challenges also need our attention, including tribal public health capacity and infrastructure, tribal public health data, the ongoing opioid epidemic, amongst others. We look forward to meaningful engagement and discussion today, and we welcome the opportunity to strengthen our partnership. As tribal leaders, we appreciate the time we have with the CDC so that we can share our guidance and recommendations on a variety of issues. This is a dynamic time, and we want to ensure that tribal leader perspectives are heard, understood, and incorporated in the agency's work.
Thank you for those comments, Councilman Tyler. Now we will continue the discussion portion of the meeting. Like other listening sessions, we will follow tribal protocol and invite our elected tribal leaders to make comments, share recommendations, and ask questions first. Once our tribal leaders have had a chance to speak, we will open the floor to other members of our audience. Our NIHB Board of Directors have a few questions to start us off with. So I would like to invite the NIHB Board Vice Chairman, Nick Lewis, to ask the next question. Nick, are you there?
Ms. Elgin, I don't think Councilman Lewis is on right now.
Okay. So
We can move to Councilman Tyler.
Nate, you want to go with that then? Thank you.
Okay. Yeah, I can
Thank you.
for Vice Chairman Lewis. So dependable data systems are a key element of strong tribal public health systems. This includes both during times of emergency, such as this ongoing pandemic, and routine operations of essential public health services. For example, according to the Public Health and Indian Country Capacity Scan, syndromic surveillance occurs in only 24% of tribal health organization service areas. Conversely, according to the 2019 Association of State and Territorial Health Officials profile, 86% of states and the District of Columbia report performance syndromic surveillance activities. Tribes, IHS, and TECs often face barriers to reliable data, such as issues of accessing data, capacity, and misclassification. A Government Accountability Office report published earlier this month reported that most tribal epidemiology centers face significant barriers in accessing CDC and IHS epidemiological data. Despite being legally designated public health authorities, tribal epicenters have had to wait months or even years for access to essential public health data. Even during the pandemic, receipt of vital COVID-19 data was delayed up to 7 months, hindering effective emergency response efforts. The GEO report cited several factors that limit effective access to public health data for tribal epicenters. Although Congress directed HHS to provide TECs with access to the data, HHS has not yet developed a policy outlining the data, including monitoring systems, delivery systems, and other protected health information in its possession that it will make available to TECs. TECs report facing an unclear and inconsistent process for requesting data and receiving agency responses, which likely contributed to delays TECs face in accessing the CDC and IHS data. Because TECs provide tribes with data to support tribal decision-making, delays or limitations in TECs' access to data may limit the ability of tribes to make informed decisions about how to address their communities' health needs and reduce the health disparities faced by the communities, our communities. Additionally, TECs face additional challenges with quality of available public health data. Multiple studies demonstrate that surveillance systems frequently misclassify American Indians, Alaska Natives, or omit them from surveillance systems entirely. These issues continue to exacerbate health disparities, including those from COVID-19. So 2 questions. What is the timeline for implementing the recommendations from the 2022 GAO report, including developing written guidance for TECs on how to request data and documenting agency procedures for making data available to TECs? When can we expect an update on progress of these steps? And what additional steps are the CDC and HHS taken to ensure all agencies within the U.S. Department of Health and Human Services provide direct access to public health data to all legally established public health authorities such as tribes, IHS, and tribal epidemiology centers?
Thank you very much, Councilman. Great seeing you again today. At CDC, we recognize that it's really important to have accessible, timely, and high-quality data for making decisions about how to protect and improve the health of American Indian and Alaska Native communities. And we do recognize that you don't necessarily have equal access to that type of data across the board. And in fact, the access that you have is limited for those who have it. We have talked before about this, and the nature of the way that in the US we collect the data is quite complex. Our health data systems are largely decentralized, subject to a variety of laws that are diverse by jurisdiction, different policies, and different data sharing agreements. We remember that CDC collects national information that comes from state and local agencies, and there are issues of who owns the data, and we have many different memoranda of understanding and what can be shared and how can be shared. We continue to work on that because we do understand that you need this data and should have access to it. But there is a lot that needs to be worked out between the federal, the state, the local, and the tribal levels to improve this access and sharing data. We are really committed to continue to strengthen that and to improve our data sharing relationship with the tribal epidemiology centers and the tribal jurisdictions at large. So based on the 2 reports that came out in the last couple of months, HHS committed to have a response, I think that within 6 months of the report, which gave us around September to have that. We have been in a couple of hearings in Congress discussing these issues. And I would like to offer the opportunity here to Ms. Georgia Moore to talk about the hearings and Dr. Reese to make comments on what the work and the funding with the text that they have been working on, it has been. So Georgia.
Sure. Thank you, Dr.
And then
Montero.
we'll pass to Dr. Reese.
Yes. The progress report is due to GAO in September, but that doesn't mean that we won't be able to provide you with updates, and we'll be doing activities before then. The first of that is next week, we'll be putting a data call out to all CDC programs that will help us inform the guidance that GAO recommended we write for techs and tribes on how to request data, a point of contact, and things like that. So we are kicking off that work in earnest. We know that we're talking to the Council of State and Territorial Epidemiologists. They have a tribal working group to talk about issues with them because we know we have to do this as a system. And one of the main things we have to do together, both from the federal level, tribes, techs, and the states, is to talk governance issues, which are very important for all of us. What's going to be collected, how it's going to be collected, how it will be used, having those agreements together. So at some point in the future, we need to convene together to really roll up our sleeves together and start working on those issues specifically so we can get this moving forward faster. CSTLT's also working with some of our data centers, is planning on convening the techs, and we can have some tribal representatives too, to specifically delve down deeper into their specific needs. And CSTLT's is definitely committed as a main point of contact in OTASA for tribes and techs to help navigate even now if there are specific data needs. We'll use all of that information to inform that plan and that response, and get moving on this way before September. Now I'll pass it over to Dr. Reese.
Good afternoon, everyone. As the Director of Healthy Tribes, we have 3 cooperative agreements that you're all likely aware of. TechFE, the Tribal Epidemiology Center Public Health Infrastructure Cooperative Agreement, is a $8.5 million a year program that is focused on funding the 12 techs, specifically to strengthen public health capacity and infrastructure to improve effectiveness of health promotion, disease prevention activities, to engage in sustainability activities after the funding cycle ends. So this program intends to reduce chronic diseases and risk factors, disparities in health outcomes, and improve overall health by building public health capacity and infrastructure in Indian country for disease surveillance, epidemiology, prevention, and control of disease, injury, or disability. And we are just rounding out the final parts of the cycle of TechFE, and we'll be starting a new one. We have full intention of working in a number of different areas to build public health infrastructure and focusing a lot on workforce development as well. So we're well aware of a number of the issues and concerns that have come up that you all have voiced to us, and we're grateful for that feedback. Our intentions are to meet the needs of the communities through these programs and support the techs in every way that we can through the cooperative agreements.
Okay, I appreciate that, Dr. Reese, Georgia, and Dr. Montero. Tribal leaders, we as tribal leaders look forward to working with you guys, working with HHS, CDC, and strengthening this partnership and addressing the important needs that we've been bringing forward to you guys. So it's much appreciated. And at this time, we'd like to open it up if any tribal leaders have any questions. If any tribal leaders have any questions, either raise your hand or unmute yourself.
This is Cheryl Yeisley. I'm on the Ketchikan Indian Community Advisory Health Board. And so the question I put, and I see an answer in the chat box, is what I'm curious about is what are tribes doing across the nation for those that they've retained for their employment that have either religious or medical exemptions from being vaccinated, to continue to follow the CMS rule and honor that, but to help the employees stay employed.
I think we're gonna have to get back to you on that one. I think there's an interplay of laws there, as you're pointing out.
Can you hear? So can I get a clarification of the question? Are you asking what is CDC doing for the tribes to keep the employees employed, or what are the tribes doing? I missed the beginning for issue of the quality of my network communication.
What are the tribes doing? What can a tribe do to help retain employees that are not vaccinated?
Okay. Yeah. So we'll go back to our health group and review that. Certainly, as with other private employers, we defer to the rules and regulations, but we'll see if there is any specific thing that we can do from the CDC to support the tribe's actions to protect the general community. Thank you for the question.
It looks like Councilman Lewis did have his hand raised.
It did. I got a message from Nate, though. They covered the area that I was going to ask about. I had some technical difficulties getting on. And so thank you, Nate.
We have a question from Chief Bill.
Thank you. This is Chief Bill. Can you hear me? All right, mine's on COVID-19 variances. Migration of risk of COVID-19 and emerging infectious diseases threat is an ongoing process. During the course of the pandemic, we have seen the emergence of new viruses and have continued to put tribal communities at risk. To control efforts to fight COVID-19 and any future outbreaks, the CDC needs to hold meaningful tribal consultations on regular basis. And I have a couple of requests and questions. The first request is, we ask the CDC engage with tribals on future COVID-19 and other infectious disease threatening plans, response, and migration efforts. And the question is, can you share any information or data about the variances that may be present in Indian country? And the second request is as we continue to move through the pandemic, we ask that the CDC continue to work with Indian Health Service and states to ensure that accurate data is being shared with tribes so we can effectively respond to future surges. And the last question is, it has been suggested that COVID-19 will become an epidemic, and California has shifted to an epidemic approach to the virus. Does the CDC plan to start offering guidance so that we can prepare to move into this phase? If so, when can we expect the guidance to be made public?
Thank you very much for those questions. So CDC is engaged on the development of our overarching approach to consultation as part of the general HHS redevelopment of policies and approaches toward consultation. We plan to have the regular consultation sessions, schedule those based on topics and needs, and continue to work directly and or through partners to schedule those down the road as necessary and as appropriate. And certainly our participation at these listening sessions and many other regional listening and consultation sessions organized by and through the different components of the HHS family fulfill that purpose. So it is not single-handed, separate or independent approaches all the time, but in many cases, we will do that integrated with others. Going back to the last part, so the pandemic keeps changing and evolving. We do forecasting based on what we find in the testing that we have going on. And as we have been saying lately, we have seen an increase in the cases and hospitalizations in many areas. I cannot tell you exactly when CDC will move into saying that this is endemic or that we are out of a pandemic, because the reality of biology and the virus is quite unpredictable, especially with variants, with viruses like the one that we are dealing with. So I know that some states have started to move into an endemic approach. Hopefully, we all as a country can do that later on this year. But we need to continue to look at the data. We cannot tell you we're going to do it tomorrow or the day after tomorrow for the reasons that have been quite clear. Last year, we were coming out of Delta and everybody was feeling quite well when Omicron happened. Now, as you well know, we are seeing increases in many different areas. Now, so I cannot tell you when CDC is going to provide guidance. Certainly, we are discussing and shifting our own approach within the pandemic to the realities of today's pandemic. The other thing is that the management of the pandemic today is not what it was a year ago, a year and a half ago. We have a vaccine. We have demonstrated how good that vaccine is, and we continue to see the need for some particular groups to be vaccinated or receive boosters, as Director Waldinsky mentioned. And we have some groups that are lagging behind others in the amount of people that is being vaccinated for many different reasons. Some is actually, some others are beliefs, some others are general perception of risk and a sense of emergency in some particular groups, as well as mistrust of agencies and governments and so on and so forth. We have developed the capacity to have treatments that are actually quite successful in addressing some of the issues that some of the patients have. So this has shifted the way that we manage the pandemic and the different options that we have in the menu. It is clear that masks have a place in many regions. And when we look at the way that CDC makes recommendations through the community levels in the different, they apply differently at different times in different areas of the country. So what we may see as a need in North Dakota may not be the same need in Georgia, where CDC is based, or in California, where you are based, because the pandemic happens at different places different. So that's one of the key complexities. And going on specifics on the data that you're asking me about the variants in Indian country, we don't have that granularity on the data. We know that some areas in Indian country are providing samples. We have had this discussion a couple of times with big providers, but looking at the data, we look at it regionally, not necessarily have the capacity by the sampling that we do for this to provide individual tribal data. So we go basically by regions, and that's the type of data that we have. I can go back and look at how granular the data can be. I'm not aware that we can discriminate by tribal data, by tribal groups. So thank you.
Thank you, Dr. Antego. And I forgot I know that AC introduced me as Chief Bill. I am also the chairman of the National Health Board and the Alaska area representative. So forgive me for not introducing myself first. But this also goes back to what Nate was talking about dependent data systems is very important, because without data, we're just guessing. Correct?
Correct. Part is, we can say that we are guessing when we don't have the data. Sometimes we are doing forecasting that is a fully approved scientific methodology. But I do understand and agree that for decisions at localized levels, either geographic or tribal, in nature. It's better to have data that applies specifically and directly to that community. At the same time, we do recognize that we are not testing every person in the country, and we don't get genomes data for every single variant tested in the country. We have a sampling system, and that's where we need to figure out how to better sample populations that have low representation, and that's one of the struggles that we have. I certainly agree with you, sir.
Oh, Ate, thank you. Nate, I'm done. And Lisa,
Okay,
I'm done.
thanks for the question, Chief Bill, and thanks for the response, Dr. Montero. We appreciate it. Is there any other tribal leaders with a question?
Chairman Davis.
Councilman Taylor, yes, Tim Davis from the Billings area. I too sit on the Blackfeet Tribal Leaders Council in Browning, Montana. And earlier on in the beginning of the pandemic in November, December of 2020, we just like to reiterate our gratitude towards CDC for, they sent a team out to our reservation where we were experiencing, we had like 50 deaths that month. And they came out and worked with our schools, our IHS and our tribal health facility to do contract tracing and I guess intervention and protocols. And we really appreciate the work that they've done with our schools, our tribe and the Indian Health Service. And then earlier on, Dr. Walensky, I believe it was, mentioned a funding opportunity with CDC for working with schools to reduce the pandemic spread there, as well as opportunities for water and sewer, and then some vaccine confidence building. I wanted to ask a question, but I know she already left, but maybe somebody from CDC can assist there on this question from our tribe would be accessing some of that resource again for those funding opportunities for sewer, water, and the vaccine confidence building and the opioid crisis that we're experiencing with overdose deaths and so forth. Last month or two, in April, we had 4 deaths from the fentanyl stuff, and we don't want any more, but anyway, she said there was some opportunities for some funding that the end date would be June 10th. Can somebody clarify that for me, please? That who do we contact? A proposal? Is it a grant? Is it competitive funding? How do we seek that resource in addition to for CDC opportunities there for the reducing the spread and also water, sewer, vaccine confidence building, and then opioid overdose responses from people that are just fed up with the, this. That was one question. Who and when, where do we apply for these funding? And is it a grant or is it competitive funding?
There are several different funding streams, sir, and I don't have all of the information with me.
Okay.
We can post it later on in the chat if we have enough time, or we can email that through the National Indian Health Board, and they can help us distribute that as they normally do, because they are a good partner in this redistribution of information. There are several different funding streams. Some of those are competitive, some of those are grants. So we will have to look at the specific details, sir, and share that with you. Georgia, I don't know if you have them.
Yeah, I can tell you most of that was through an existing cooperative agreement. Those supplements were only for current grantees, I believe she was referring to. However, I've written this down to follow up for you. There are still ways that we can assist with wastewater surveillance. I know even without that cooperative agreement, wrote down looking into opioids resources for you. Was there a third thing you wanted us to follow up
water
on?
and sewer resources there, and then the building of the vaccine confidence within
Vaccine confidence, thank you.
Because last
Yes.
about a month ago, one of our former community health nurses who really was promoting vaccine got a booster, and she contracted Bell's palsy. I just wonder if there's any more cases like that happening out there. And also the last one would be on masks. Earlier on in the pandemic, as we all know, the big controversy there is that only those medical people need masks. The general public don't. And the CDC came out with a restatement that everybody should wear a mask, even if it's just a bandana. Then pretty soon it was, oh, you better wear an N95 thing. And now we're just wondering, The efficacy, we understand that masks were very efficacious for us, but our state of Montana 2 years ago lifted the mask mandate, but our tribe kept it in place until about a month ago. And so now there's some people wanting that to be reinstituted. Does CDC have a recommendation that we should start wearing masks again? Because I think we had like 22 cases pop up over the last 3 days. So, and is the severity of the hospitalizations, the death, somebody said there's going to be 1 million deaths here this week, but are we coming to kind of like, we've heard the term endemic? Is that kind of coming on the horizon, or what is CDC's take on this? To, like we did lift the mask mandate, it's optional now. And now there's some people saying maybe we should reinstitute it. Where does CDC fit in all this again? Are they recommending just, use your own logic? It's up to you if you want to wear a mask or whatever. Because I know in public transportation lifted their mask mandates on planes and, buses and so forth. It just says recommended. So where are we at with that on the masks for the CDC? Do they encourage that in N95s, or can they just go back to bandanas again?
So a couple of things. Thank you very much for that question. You are highlighting one of the complexities of communication during pandemics. First of all, the science evolved during the pandemic. There was information that we didn't have at the beginning. And as time went by and we were able to run some trials, we confirmed that the use of masks protects the user and the others, right? And from that perspective, at the high of Deltas or Omicron variants, we were quite adamant that people should be using those masks all the time. The reality is that people get fatigued with some of these recommendations, and it has become an issue that actually has been politicized. I will not engage in that discussion here, but the reality of the science is that using a mask helps decrease the risk of infection and transmission of many of these infectious diseases. CDC and Dr. Walensky actually went public 2 weeks ago saying that given the trends of transmissibility, the transmission of this particular type of virus in some geographic areas, we should strongly consider the use of the mask in indoor spaces in congregate settings. We are not telling people that you need to have the mask 24/7. We are not telling them when you are outside, you need to have it. So there is no mandate from CDC. But based on what we are seeing on the data, we really want to recommend people to strongly consider the use of a mask, especially in those indoor congregate settings when you are around many other people. I have been traveling. Actually, I am right now in the South Pacific, 3 a.m. here. And on the airplanes, I am using the mask, even though it's not a mandate. And I have the boosters. And I don't have any of the risk factors, but I do that as part of my personal social responsibility toward the others. Because I'm traveling and around many people that I don't know, I don't want to get infected. And maybe I am not symptomatic, and I will give it to somebody who is not, who is a high-risk person. So the reality is that there is a lot that we can do still to support each other. And from that perspective, the use of a mask is one of those things that is not a complex thing for us to do, and that it is a great tool. Now, when you ask again about the endemic and versus pandemic, as I said to one of the previous speakers, I think that it was the leader from Alaska, we cannot tell you when the pandemic is going to end. We keep looking at the trends. We know that Omicron and some of the sub-variants of Omicron are increasing and taking precedence over some others. We are not seeing an increase in severity, but we are seeing an increase in case and hospitalizations in many places around the country. So I can tell you that right now we are going in the opposite direction of getting into an endemic or getting out of the pandemic. So all the measures that we can have, if you are sick, stay home. If you are eligible for a vaccine, get vaccinated. If you are eligible for the booster, get the booster. If you can use the mask because you are in a congregate setting, use the mask. Are perfect. If you are at high risk, make sure that you are not exposing yourself unnecessarily in situations of high risk. those messages, those measures still apply, and we encourage the population to act accordingly. Thank you.
Dr. Matero, again, is there any correlation with the booster and the lady I mentioned earlier that
The Bell's palsy. Yeah. I have not seen data suggesting that. We need to remember that there are many pieces of information that we are still processing. Last week, the FDA issued some particular messages around the J&J vaccine. We know that vaccines have been associated with some other conditions. I have not seen specific data on the association with Bell paralysis, but certainly we're going to look at it. Hopefully, her case has been reported through our VERS systems, and that's the way that we identify trends in populations. There is a time association between many things that are not related to the vaccine. I got the vaccine and then I fell, or I got GI illness, maybe due to something else. It's just that it's associated in time. But it is important to get all of these different events so we can trace them and track them in time. That's the way that we know if it is or is not related. I will have to go back and look at all of our reports, because Bell paralysis, which is, for those who don't know what we're talking about, this thing that we have in our face, and we lose control of a side of our face because the muscles get in, the nerves get inflamed. I don't have data proving that, so I will have to go back and look, sir. Certainly, we will get back to you with information on that.
Dr. Matero, really appreciate it. One last question is, like we've had some pushback here from people that didn't want their children vaccinated because they were afraid of sterilization. And some of the ingredients of that vaccine, utilizing the fetus, some of the people were religiously opposed to that. And so those children, is there any, because like they were talking, maybe they could get autism from it, or would sterilize them later in life. So I know that is still a ways away, because those children have to grow up before they begin reproducing. So is there any type of, scientific data that does show there's a correlation between maybe autism or sterilization from any of the type of Moderna or Pfizer, or I think they came out that J&J one? Is there any correlation? And like this goes along with building vaccine clubs, because some of our local people said that they didn't want that foreign injection in them because it could cause sterilization in their children. What kind of pushback does CDC have to highlight that's not the case?
Thank you very much for that question. The issues of vaccine confidence are actually quite important and complex to manage, because they respond to many different cultural issues. And I'm not talking about tribes specifically as a culture. I'm talking about us as an American society. There is a lot of misinformation. There are people that have some different points of view, but the facts are the facts. And the science has been able to prove categorically, unequivocally, that there is no correlation between vaccines and autism. That has been debunked many, many, many years ago. It was based on a paper that was actually removed from the scientific literature because ethical and methodological concerns. But the topic was left in our collective subconscious. So every time that people is talking about vaccine, oh, but the children this and the children that, the components of the vaccine have been fully tested. We know that they are safe. We know that there is a really small, tiny minority of people that may have allergic reactions to them. We keep tracking, as I said earlier, when you asked your other question, we track the adverse events that occur in the population that are vaccinated, and contrast and measure the occurrence of the same events in populations that are not vaccinated. That's, as an example, how we identify that, yes, there is an increase in the number of myocarditis events in young adults. But at the same time, we were able to prove that the number of myocarditis events in young adults were lower than in those that were not vaccinated. So the disease, COVID, the SARS vaccine actually prevent more cases than what it may be tied to. And the complexity of the analysis of that information, and sometimes our own technical constraints in the way that we speak, make it really difficult for us to get those messages to the public. That's why we need trusted partners like you, the leaders of the communities, understanding this message and being able to transmit to them that no, there is no data showing that. And in fact, we have data with the sterilization. That question came even before we knew what the vaccines were going to be. And we have used most of the components of those vaccines for a long time. And we know that they are not tied to that. Then there were concerns about their possible impact in pregnancy. And actually, we know that COVID as a disease has an impact in pregnancy, affects the fetus, and so on and so forth. So the vaccine actually protects them. The vaccine increased good outcomes in the population that is pregnant. That's how we were pushing really hard for pregnant women to get vaccinated, because we don't want something else impacting them and affecting them during that time. So that's what we have in the data. And the vaccine for younger kids under 5 has taken time, because we want to make sure that we have all of the safety data. And we, CDC, we wish to have that vaccine, but we are not going to rush it. And the data is being reviewed now by the FDA, and we hope that soon we're going to have a vaccine. And the reality is those vaccines are safe for the population that we are recommending.
Dr. Montero, I thank you for the time. And also the one last little deal there. I had a person that was a nurse, doubly vaccinated, wore a mask all the time, and caught COVID and died. And so we had a lot of people saying, why get vaccinated? Why wear a mask? You're still going to get it and die, kind of thing. What type of, I guess, educational effort can we do here to say, no, that's not the case? There was just 2 people that, or I think we lost 6 people that had been vaccinated that did pass from COVID. So across the nation, is there a big number there that we could say, no, that's not the case? That was very small. How would we combat that people's fear of, or I guess, reluctance to get vaccinated and wear masks, because this other person did that and they still contracted the virus and died? That was one of the things we faced here. We had, like I said, 6 people passed that had been vaccinated.
So again, thank you very much for that question. And that's one of the things about risk communication. Vaccines are really good. But we have never ever said that it's 100% protection. That's why we need more people vaccinated, because it's the collective vaccination of a community, the one that decreases the transmission of the infection of the virus within that community. The vaccine works. The vaccine works quite well for most people. The vaccine has proven a dramatic decrease in mortality and severe hospitalization. The vaccine has not shown to prevent 100% of the fatalities or 100% of the severe illness hospitalizations. So that's why vaccine by itself doesn't work. We need the vaccine, we need the mask, we need the not exposing ourselves to situations of high risk, because it's the combination of all of this what is going to provide what we call the herd immunity. So vaccines are good. And that's what is taking us this far. And sorry, the other thing is that there are different levels of protection for different strains. And that's why you hear in the media that we talk about the possibility of a different vaccine in a year or in 2 years. And I cannot tell you if we're going to have one or need one, because that's part of the ongoing evolution of the virus and of the science. So overarching message, vaccines are good. They decrease and more than 90-something percent, I don't recall the exact number, mortality and severe hospitalization. They, depending the age group, they may decrease infection by 50%, 60%. But then if you are at a high risk and you get infected, that is the people that we are saying again that has an issue. So it's the combination of measures and our full engagement as a community, the one that will help us be protected as a society. And I'm sorry for what you are experiencing in your community. The numbers seem quite high, but we continue to see that the vaccine is effective.
Likewise. Oh, thank you very much, Dr. Tune. Thank you. And you're down in, you say it's 3M where you're at. I'm sorry to ask these questions at that time, but thank you. God bless. Thank you very much.
Thank you. Yes, sir. It is. I am in Guam, the Pacific.
Okay, Councilman Davis, appreciate the questions. Dr. Montero, appreciate the response. It just shows how important that information sharing is, especially with us working together and getting information in a timely manner. So our community members, our tribal leaders aren't confused in the changes that have been happening basically overnight. So truly appreciate that. Is there any more tribal leaders on the call that have any questions?
Diana, you have your hand raised.
Councilman Nate, could I go forward?
Okay, yes. You have the floor.
Thank you very much. So good afternoon, Dr. Montero, and very interesting listening today. My name is Diana Zerl. I serve with the Canarsie Tribal Council in Kenai, Alaska, and also serve as the chair of the Alaska Native Health Board. You know, I've been listening very intensely today, and your last conversation was very helpful as well, because I think one of the things that we see is the continued pushback as we see some breakthrough infections. And even though we do know that the morbidity and mortality when there is breakthrough are less, not eliminated, but less in the vaccinated or those that are boosted, I think that one of the things back in February, the CDC Tribal Advisory Committee met with tribal leaders, and we talked about at that time the need to understand long COVID, or I guess they're now calling it the post-COVID conditions. And I think that's so critical, and how to get that information out there and getting it out there in a timely fashion, I think will be very helpful. Because it's one of the things I think that we see in those that are giving the pushback on the vaccines or on the boosters, is the, you know, not having that information out there what the long-term effects are. And we are beginning to see that. And I know that studies have been being performed, especially in the UK and elsewhere, to demonstrate that. And I think getting that information out there is going to be very critical, because I know all the acute phases are very, very critical, most certainly, but the impact on us and future generations, we just do not have a full import of that at this point. So I guess the question is what steps is the CDC doing to take us to this end, and how quickly do you see us getting information? And I realize studies have to be done, but with the volume of information that we have out there beginning to collect, I think it's going to be critical for us to hear that, because it is one more tool to help educate those who may be making the, you know, back and forth on the decisions, and more importantly, on the booster, you know, whether to do a booster or not as they see the breakthrough. But again, knowing that there's that impact on cognitive issues, possible long-term respiratory effects or cardiovascular effects, children. I mean, that is all those things that are the unknown that will give us tools in our belt to continue to combat this as it goes forward. I'm just wondering if you could give us some kind of status on that. Thank you.
Thank you very much for that question, and you are absolutely correct. This is one of those things that is part of the evolving nature of science. Those of us who are in the clinical field know that there are things that we don't know. And I think that there was a Secretary of Defense who used to say, the problem is when we don't know what we don't know. When the pandemic started, the emphasis for all of us was to look in the acute cases. Then we started to see these unusually severe conditions in children that were quite acute. And then after time went by, and we have been more than 2 years in this pandemic situation, we started to see the mid and long term effects that may have been tied to suffering the infection with the SARS virus. As you mentioned, we have seen cognitive issues in many different groups, not just young kids, but adults as well. This fog, brain fog, that you don't really have clarity of thought and things like that, but we have seen some other physical conditions. So we are working really hard to do an evaluation to identify them. Because one thing is that we don't even know exactly what all the symptoms are. So we are working hard. The NIH has a whole research project going on around this, because we need to understand it in the long term and develop the right follow-ups. One of the core things, and I know that you understand exactly this problem, is that causality. Do we know that this was caused by COVID? And how do you demonstrate that the person had COVID? Early on in the vaccine, in the pandemic, we didn't have testing. So those who suffered the vaccine back in January, February, or March of 2020, they were not tested because we were just creating the test. And many of them have symptoms. Can we have a full association between this and that? So there are many technical aspects on this that we need to be careful. We have in our website, and actually updated late last week, a whole page on this condition. And for healthcare providers, we are doing what we call the COCA calls, the clinical outreach calls. And there was one this week. So my team, maybe they have access easier than what I do here. They can look into the Coca-Cola websites and post the links to the different calls. So for the healthcare community, we are doing trainings, how to manage, how to identify, and where we are at. And for the general community, we have updated our website and our web pages on what is tied to the long post-COVID conditions. But we all need to recognize that we don't know it all. This is a field and an area that we are just starting to identify and work on, and it will continue to change as we learn more about it. We need to be able to explain this message to the public without creating a lot of fear, because people will think that this is a gimmick to get them vaccinated or things like that. And so we need to be careful in how we message and manage the information and education about those particular aspects. So we have a multi-pronged approach, doing the research, confirming the cases, doing the tracking, confirming the associations, getting the education to the clinical community, getting the resources to the general public. So thank you for bringing that up, because it is really important for all of us to remember that.
And thank you, Montero, Dr. Montero. If I could do a follow-up on that, a couple of things that you said that triggered some other thoughts is, as you said, early in the stages in early 2020, we weren't able to do the testing. And now we've transitioned to where we can do home testing. And in some respects, one of the things that I continually send out as a message is that there is no shame in having COVID. The shame would be is not reporting it and allowing those that you've possibly exposed to seek the treatments that they need, or to monitor themselves to prevent the issues. So again, I think we're kind of moving into that, and I'm curious how we'll measure that, because not everybody reports their home tests. And again, as I said, there's no shame in having it. It's the fact of not helping others to understand that you may have been present with them and exposed them unbeknownst to yourself. It could be a vaccinated person who's not symptomatic, and so forth. So that I think is going to be real critical, as well as what you said. And I don't want to go into scare tactics, certainly, and I do appreciate that we have to do it in a manner that is very respectful and going to be a respected response, instead of that we're pushing something on people just because we want to push it. And that is not a good situation either. But getting a handle on those cases that are, that are self-testing and no response. And the other thing then is, the ability to try to get out the message about the treatment with, in the early phases of having COVID, that help to prevent some of the issues that we've talked about. Again, it's just an education. I think it's very important. People have the right to make choices that they want to make. I do respect that, but again, the more information we can get out there and use in our educational tool belt, I think will be helpful. So I appreciate your comments, and not necessarily looking for a response to that one, but just I do appreciate your comments on that, and thank you for today.
Thank you very much. Let me take one of your comments because it's a point that I maybe didn't make, and you highlighted this. Is there is no shame in getting COVID. Shame if you have it and you go and purposely expose others. Many people may not want to be tested because they know that may have been exposed. And then they don't want to be tested because they cannot lose work, or they don't want to lose work. That is the wrong approach as individuals, as members of communities. I carry my own test because I have been traveling so much and in so many airplanes. I said, I need to know what's cooking with me because you change time zones and you don't sleep and you feel sick. I need to know if that's COVID or it's just jet lag. It's my personal responsibility. I wish more people will be doing that. And yes, many people are being tested and are not reporting, and it's fine. We don't need to know every single case. We don't need we don't need to know exactly how many people got it. What we need to know is that we, as members of our communities, are taking this seriously and responsibly, and we are testing ourselves and acting accordingly. When we test positive, we stay home and we let those who were around us that may have been exposed know, so they can do the same. That is a key component of decreasing the transmission of this particular infection, and it will help us get out of this pandemic. So thank you for bringing that up.
Yeah, and again, just to follow up on that, I too, just this week, am traveling to 4 different places over a course of 2 weeks. And this morning, because I'm getting ready to go into an area that requires testing before you get there, did my test, and gratefully it was negative. I mean, but I'm vaccinated, double boosted. You go through the whole scenario, but I do think that we do have to be responsible. And again, there is, I always emphasize that, and thank you for emphasizing that as well. There is no shame in getting COVID. It's just being responsible once that occurs. So thank you.
Thank you, Nick.
Could I add a quick comment to Ms. Cyril's question?
Yes.
This is Juliana Reese. I just wanted to add something you mentioned. There's multiple presentations, there's these different phases, and it's confusing. So I think there's, as you said, there's no shame in getting COVID, but I think what's really important is that community education and that communication that keep the conversation going. We're experiencing a lot of COVID fatigue in communities. People just want to be done with the pandemic and move on. And it's difficult for people to kind of wrap their heads around having to test more, figure out how they're going to get tested, if it's going to be a self-test or a clinic test, but keeping those discussions going so folks who may have symptoms are able to know the resources and reach out to clinics or healthcare providers and talk about those, because as the pandemic evolves and the virus evolves, we really need to be documenting what's happening in our communities and helping people decipher what's happening in their bodies. And as we all know, a component of long COVID is stress. And so the pandemic stress, the financial stress, all of the stresses that come with being worried about your health in infecting others, or what's going to happen to your community in the future, all that impacts how you respond. And so I think one of the biggest things we can do is keep that communication open. As things come out in the literature, we find more ways to communicate that back and to within groups. And that's one of the strongest things that we can do to kind of protect our community right now. But I just wanted to add to your comment about no shame in having COVID. COVID is also no shame in going in and asking questions and getting evaluated again.
Okay, appreciate the question brought up by the councilwoman, the response by Dr. Reese, Dr. Montero. I think it's important to know, there is a lot of worry about long COVID. the long lasting effects, the strains it's going to put on our healthcare facilities, our budgets, having access to treatments, having access to funding, learning more about the long-term impacts, whether that's lung damage or whatever the case is, internal injuries to lungs, breathing, you name it. So we do appreciate the response and look forward to working together closely as long COVID is addressed. So very much appreciated. Is there any other tribal leaders at this time?
We have
willing?
Councilwoman Parker.
Thank you. Thank you, Councilman Tyler. And Dr. Montero, I just want to thank you and George and your team for being on the call today. And I realize that you're a long way from home, and I hope that you have safe travels getting back to the United States. And we just want to wish you well and hope you're not getting too sleepy during all this, during this meeting right quick. But I'd like to change gears a little bit and talk about emergency preparedness. And being an Oklahoma tribe, you know, here where we have a lot of tornadoes, that's something that's really important to us. But planning for, responding to, and recovering from man-made or natural disasters and emergencies in tribal communities can pose unique challenges. Among other challenges, these can include lack of resources, the complexity around jurisdictions, the lack of understanding among partners working with tribes. Furthermore, many tribal nations are in rural or isolated areas, making them the first and only responders to emergencies or man-made or natural disasters. As a result, tribal preparedness and response efforts may differ in Indian country. So we have some requests. We ask for increased funding for tribal nations to increase emergency preparedness and response capabilities. Investments in tribal emergency preparedness and response has not been on the same level as state and local jurisdictions. Funding is needed to ensure tribes have sufficient staff, training, and equipment to plan and respond to disasters and public health emergencies. The CDC provides funding to build preparedness and response capabilities. Currently, the CDC has public health emergency preparedness cooperative agreements with all 50 states, in addition to 4 cities and 8 U.S. territories. Question, is there any update as to why tribes are not included in these cooperative agreements? And what is needed for tribes to do to be eligible for this funding? We ask that funding go directly to tribes and not be funded or funneled through states. We have seen repeatedly that funding for tribes being passed through the state does not work and is not efficient. Tribes are sovereign nations with the authority and responsibility to exercise the right to protect their citizens and tribal lands.
Yeah, I am mute. Good afternoon, man. Great seeing you, and thank you for your support and your work in the CDC's Tribal Advisory Committee. It has been quite a great experience having your leadership there, so thank you very much. Going into your question, yes, we have been in the process of identifying better ways to partner with tribes. CDC's funding for emergency preparedness comes from Congress with some specific mandates and appropriation language that tells us you need to fund this type of organizations or entities. In some cases has proactive limitations, in some cases has had tacit limitations. But we cannot forget that many of the preparedness components are not only directed to CDC, but to other organizations within HHS. So how do we work with the ASPR, the Preparedness and the Associate Secretary for Preparedness and Response? How do we work with IHS, and what funding goes to each part of the different components of the HHS family is important in this discussion. Actually, I do not have first-hand knowledge of all the different funding streams that go to other partners that are funding response components around the country. Within the COVID-19 response, as you well know, because we have discussed this on the PAC many times, we had this grant over $200 million that went on grants toward many tribes. the reality, and we are closing, and we presented some of this data to the Tribal Advisory Committee, is that to receive funding, you need an infrastructure to respond. And how do we partner and how do we fund needs to be part of a longer term build-up of a tribal public health infrastructure. The scan of capacity showed that we don't have the capacity to respond. So the funds to prepare need to help us build that. I know that the CDC Center for Preparedness and Response has included some tribes directly in some of the funding mechanisms. We have different components of the funding and different funding mechanisms. In one that gets organizations and like a retainer, you are approved but unfunded because we don't have funds, but they are willing and able to receive funds directly to create a response. So big tribes that have big health departments like Navajo or Cherokee or Chickasaw or others can do that quite easily. In some other groups, we have tried to fund your area organizations that act as a consortia type of umbrella agency that helps smaller tribes to do things that work for their tribes. There is true in the concept of economy of scale. We see that in all of the different things that we do in health. From clinical practice, if you are an OBGYN and you don't have 100, 200 deliveries per year, you lose your skill. A really small organized tribe that a few thousand people does not have the capacity to create an independent public health agency. Neither should try to do that. So how do we help those smaller tribes, smaller nations, to create a structure that allows them to do this? That's where, in some cases, the tribal epidemiology centers as public health agencies come and can help as part of this holistic approach to work with Indian country. We are exploring all of those options. We have had the discussions about how do we build public health tribal capacity, which includes regular conditions and emergency preparedness. And we will continue that discussion. It's one of the topics that we have for our next Tribal Advisory Committee meeting, actually in Oklahoma, in Talua, in August 3rd. So we continue to work toward that. But your question is quite important and raises a point that is not solved from the CDC's perspective. We are working in how to do what is right so we can continue to support all tribal nations in the ways that is appropriate so they can protect their members.
Thank you. Thank you very much. Like I said, I appreciate you being up so early where you're at, just to be with us and to be able to answer some of our concerns and our requests. So I just want to thank you and Georgia again and your team.
Thank you, man. I have a great team. They are amazing. You know that. We are here to serve you. So thank you for that.
It looks like we have one hand raised from Chief Bill.
Thank you, AC. Can you hear me?
Yes, we can hear you.
Thank you. Chief Bill, Chairman of the National Health Board, Alaska Area Representative, and a board member of the Alaska Native Health Board. Dr. Matero, I have a question for you. Vaccines, boosters, and masks help stop the spread of COVID-19. Has the CDC looked into a nasal spray that can prevent COVID-19? Looking into the science of this thing called Cofix RX. It's SARS and COVID cold and flu spray. You know, when we wear masks and we go into a crowded place, apparently these 8 doctors in Michigan or whatever come up with this nasal spray that helps, it says it destroys the virus within 15 seconds. Has the CDC looked into the science of a nasal spray to help stop the spread of COVID?
Thank you very much for that question. And that's one of the important pieces of ongoing science development and how it gets communicated to the public. From the federal government's perspective, the NIH is the branch of the health department that runs trials and analyzes that information. The FDA is the branch that looks at the pharmaceutical products and their value. That's why they have to license a vaccine before CDC makes a recommendation. We make recommendations after the science is validated independently by our sister agency, the FDA. So when we get data from them, we will be able to provide an opinion on that. We don't have that yet, so we cannot provide an opinion on the value as a population measure of this particular spray or many other things that you may see on the media advertised from scientific communities or pharmaceutical groups doing drugs development. So no, we don't have enough information to make a comment, and we will make comments when the FDA reviews the data.
Awata, thank you. And it just goes to show how much important data is too, that we get to keep us all safe. So Awata, thank you for that.
Okay, appreciate the questions. I have a question, Dr. Montero. I too appreciate you being here with us, considering where you're at, what time it is over there. My question is similar to the question that Connie had asked, and it's really zeroed in on funding. So the 2019 Public Health in Indian Country Capacity Scan found that consistent and equitable funding was one of the two most fundamental priorities for tribal public health. We do truly appreciate the administration's recent investment in tribal public health infrastructure. It's a great step forward, but further investment must be made to ensure that tribes be provided equitable access to non-competitive funding streams to build their public health capacity that allow maximum flexibility and sustainability. For example, in the President's 2022 budget requests $160 million for preventative health and health services block grant, the same funding level as in fiscal year 2021. However, of the 61 fiscal year 21 grantees, only 2 tribes were awarded funds totaling $92,386 of the over $145 million awarded. That's roughly 0.64% of the total funds awarded, which is neither equitable nor proportionate, given that American Indians and Alaskan Natives make up roughly 2.9% of the US population. So while tribal health organizations maximize their available resources to administer various public health activities and services with the existing public health workforce, tribal public health remains inadequately resourced. So the request to achieve equitable and stable funding to support tribal public health infrastructure, we request a minimum 5% set aside across all CIOs for tribes and tribal organizations to integrate tribal public health needs and priorities across the entire CDC and its programs. When possible, the CDC should use allocation and distribution mechanisms that allow for all federally recognized tribes to get funding. Funding should be provided in ways that trigger the least administrative burden. In addition, in respect to tribal sovereignty, the CDC should ease funding restrictions that may limit how tribes can use the funding. Tribes know best what will work for our communities and should have the agency to use the funding to address the most pressing priorities for their communities. The CDC should partner with IHS through an interagency agreement to pass funding to tribes through IHS so that tribes can compact and contract the funding if they so choose. This does not reduce the responsibility for CDC to provide training, technical assistance, and other support in the same manner that they would for grants through their own CIOs. There are several bills passed, and you talked about Congress's involvement. So there are several bills passed or currently in Congress that utilize tribal set-asides. In most cases, funding is transferred from the CDC to the IHS to administer, including through self-compacting and self-contracting. For these instances, when IHS administers funding, what technical assistance, training, and other resources will CDC provide to the recipients? Tribes are public health authorities and should have equitable access to all available funding. However, tribes are often denied funding due to overly restrictive funding categories that favor larger entities such as tribal epidemiology centers or tribal consortiums. What is the CDC doing to ensure that eligibility criteria do not block tribes from essential funding?
Thank you, Mr. Tyler, Treasurer Tyler. A lot of things in that question. So let me start from your first point, the block grant. The block grant is a historical funding stream created by Congress maybe, I don't know, 40 years ago or so, that was an amalgamation of many different funding streams. And it went to those who were already getting that particular type of funds. So there were, I don't remember how many, 4 or 5 different funding streams that were put as one. And it's in the language of the appropriation, how we distribute the money. So it's not up to CDC to change it. So I know that only a few tribes get directly funded there, but that's a historical remnant of where the money came from. So that's not up to CDC to change. The question of the 5% and our partnerships with IHS have been raised many times. We have discussed that one in our Tribal Advisory Committee, in our listening sessions, and in our budget hearings, as it happened recently with the HHS budget hearing. When we are talking about funding directed to tribes, I do agree with you that there is more that needs to be done. Mathematical set-asides are tricky formulas because there are components of funding that are addressing specific situations and conditions that do not happen equally across the board, and they need to be targeted. That's item number 1. Item number 2 is appropriations language, as I said earlier. Congress decides for whom the money goes. But then the other thing is a misperception that CDC is the only funded agency for public health. There are many other pieces that go to different agencies. And it has happened that Congress already makes the separation of, we do this through CDC, and we do this through IHS, and we do this through SAMHSA, and we do this through HRSA, and we do this. So thinking that the CDC budget is an island is not necessarily the right approach. I don't disagree that we need to do more to engage with tribes, and that's part of the efforts that, as you are, as a member of the CDC's Tribal Advisory Committee, heard that we're looking into how to increase funding, how to drive more funding, how to use vehicles that are not competitive, that are flexible, that are in the form of grants. And that is where we are going. Dr. Reese is part of a center that has created some of the most innovative financial vehicles, like to fund tribes. And actually, if I remember correctly, a couple of years ago, we looked at that, and from the National Center for Chronic Diseases, more than 3 or 4% of the budget was specifically targeted to tribes. So progress has been made. We are not at the point where we can say that it's a standard that every center is doing that. From the funding that comes to our center based on the appropriation language and so on and so forth, we have a big proportion of funding going as well to the tribes. So again, it's a multi-level answer. So it's not all CDC's budget. We need to talk about the CDC's component of the budget that goes out. And of that, we need to see what already was redistributed to IHS or through other organizations, and how we look at that budget as a whole. So more work happening, sir. More needs to be done. I'm looking forward to continue to discuss those with you through these sessions and through your active participation, which has been quite good and active in our CDC's Tribal Advisory Committee.
Okay, Dr. Botero, appreciate the response. And I do look forward to working with you and the other TAC members. So very much appreciated. I don't, at this time, I don't see any other hands up besides Zach. And I believe Zach is a student. If nobody has a problem turning it over to Zach, he's had his hand up for quite some time. And if Zach can introduce himself and ask his question, we appreciate it.
Yeah, hey there. My name's Zachary Erding. I grew up in Flagstaff, Arizona, next to the Navajo Nation. I am not Native. I have served, I had the honor to serve really the Warm Springs Nation and the Alaska Native Medical Center as a medical student when I trained at Oregon. And now I'm a postdoctoral research after finishing at Oregon with my MD PhD in 2020. I mainly study head and neck cancer. And I'm also studying data science and EHR big data, which we'll give a talk about tomorrow, along with my colleagues from the Navajo Nation, Dr. Ethan Paddock, who's currently a resident at New Mexico, and another MD PhD student, Jonathan Credo at University of Arizona, where I also did my undergrad. So that's kind of where I'm coming from. And as I've been doing data science as a postdoctoral researcher and finding the different roadblocks to data sovereignty, data access, data funding, evolution and modernization about data, which I'm learning a lot about during this conference. I think back to this comment earlier in this discussion about it being nearly 7 months for the COVID data to come to one of the tribes. I don't remember who actually was speaking early in the conversation, but I've found similar roadblocks, which we'll discuss in more detail tomorrow. So I won't go into that now. In terms of data access at the end of the day, and it seems kind of absurd that from the Indian side, from the IHS side, or from the actual tribal, citizen side, they're having trouble getting data access to their own access, to their own data. Kind of makes sense for me to have more roadblocks as a non-tribal researcher trying to collaborate with different tribal entities to further native health, that I should have more roadblocks, mainly related to data sovereignty and data agreements. But for the own tribe to not have access to their own COVID data when presumably they're even collecting it, or to know what tribe a COVID test is related to, that really the data got downgraded by converting a tribe into a region. What are the bottlenecks that make 7 months a standard turnaround time for getting their own data? Is it like the CDC has to distribute this data or somehow filter it? So I'm getting a little long-winded here, but kind of the main goal that I'm trying to get at is, what are the bottlenecks that lead up to a 7-month delay in delivering the data to, themselves, basically?
Dr. Dank, thank you very much for that question. As we said earlier, there are many things about data that have to do with who owns the data. CDC receives information from their state, tribal, local, and territorial partners with memoranda of understanding, where we agree not to release or redistribute the data, and we publish it in an aggregate ways, and so on and so forth. Data sovereignty goes in many different ways, and it's not just who owns the data, but who distributes and what access you grant to others to have that data. As you may imagine, we cannot break those agreements. It's the same thing that if a tribe gives me data and I sign that I will not redistribute, I cannot redistribute. So the unfolding of this history has been the core factor delaying a more effective and efficient approach to that data. The other one is the reality of the quality of the data. As we have said many times, the data comes incomplete. We don't know if the person is white or African American or Hispanic or American Indian or Alaska Native. And from there, we don't even know what tribes they belong to. That data is not collected, and if it's collected, it's not transmitted to all the levels that may want to see it. And then for publication and release, when there are small numbers, as you will understand, we cannot release data that will lead to identification or constructive reconstruction of records, positive reconstruction of records that may allow to identification of cases from the national perspective. If the local health department needs to work on those, it's different. If a tribal health department needs to work on that, it is different. And that is at the center of the complexities of the management of data. CDC is engaged on an overarching data modernization initiative. Most pieces of information are collected by clinicians. The person is sick, you go to a physician, to a nurse practitioner, to a qualified health center, to a clinic, to a hospital, and they collect the information. What information gets collected, assessed, and transmitted when and where? So it goes to a local health department, it goes to a state directly. So we are looking into all of this and heavily investing. This is one of the priorities for the director. This is a priority for us as a science-based organization. And in that modernization, we're looking at what the right type of agreements for data sharing toward the future are. We cannot look only at what we were doing 10 years ago or 15 years ago or 20 years ago when data collection was manual or transmission of data was done through fax. Today, if we are collecting information electronically, it can be and should be transmitted electronically, and that speeds up transmission and sharing. We know that that will decrease initial quality, and we need to figure out what the impact of that is. We have several systems like the syndromic surveillance and the emergency room surveillance systems that require titration of how do you respond, because initial data may be miscoded and things like that. So how do you include the quality improvement processes for releasing of data? So it is a complex enterprise. We are absolutely and totally committed to improve that for everybody, and that everybody includes the tribes. Ms. Moore has been in some of the discussions of this and representation of CDC with other centers. The Center for Surveillance, Laboratory, and Epidemiology Services is leading the effort. We have several different projects looking into that. And as part of the GAO reports and other reports written at this, we are actively looking in the answers, and we will be responding to those, as Ms. Moore said, by September. But I just wanted to give you more situational awareness of why we have those roadblocks. It's not necessarily on us, it's the system that we had before the pandemic, and it's the system that we're trying to change with an eye on the future. So thank you for the question.
Yeah, thank you so much. That's very just insightful and educating. So it's an honor to be here today, and thank you for having me and my colleagues, and we look forward to presenting tomorrow. So yeah, thanks again for your response. Very, very helpful.
Absolutely.
Okay, appreciate your passion, Zach, your commitment and passion and concerns, and look forward to tomorrow. Dr. Montero, appreciate that. Tribal leaders, I appreciate the dialogue that we held today, and at this time, that's going to wrap up the Q&A portion of this, and I will turn it back over to Chairwoman Lisa Elgin.
Thank you. Looks like we come to the end of our time. I want to thank our speakers very much for joining us. And all of you who shared your thoughts and comments and questions. So just any final comments from you and your team, Dr. Montero, you could do right now.
Chairwoman, thank you very much for the opportunity. It is an opportunity for us to learn, and it's an opportunity for us to improve and grow this partnership as a relationship of government to government. We do really take all the comments to heart. We bring those back to CDC, and we'll continue to work on improving. I used to be an epidemiologist. Before I came to work at CDC, I know how important data is for action. We are really committed to figuring this out. It will not be a fast, quick answer, but we want in this general data modernization initiative at CDC to really do what is right for tribes. So we will continue to work. Thank you very much for the opportunity to listen to the concerns and suggestions from the community. I appreciate that.
Well, thank you, Dr. Montero and Georgia and Juliana for being here. We appreciate you being here today, and we know you're traveling, so safe travels to you, Dr. Montero, wherever you go. We'll be following up with you and your team on the issues discussed today. We know that having this time is important, and it's critically important that we track the progress of these recommendations. We trust that the agency will help to support our recommendations, and tribal leaders across Indian country will work to make sure lawmakers also know what our priorities are. We invite you all to join us for the NIHB VH listening session, which is coming up directly after this session. And again, the tomorrow for conference opening plenary is at 11 Eastern time. We hope that you will join us for those as well. Lastly, please remember to stop by our virtual exhibitors hall and marketplace to see the great offerings and connect with the vendors. Thank you again to our speakers and audience members. Please take a few seconds at the end of the session to fill out the evaluation. You can find the link that says, please fill out the session evaluation under the session description on the session page in the online conference agenda. This feedback is critical for the work that NIHB does and helps us improve our listening and consultation sessions in the future. So on behalf of the entire NIHB board, I wish you a good week and hope that you enjoy the rest of the conference. So go in a good way today. Thank you, everyone.
Thank you.